Welcome to the inaugural lecture of Professor Clive Beggs. Our university is one of the largest providers of professional education, training, research and development in the UK, transforming lives and prospects of thousands of individuals and organisations every day. Our research here is not just about transforming lives, it's about changing the world. From looking at the way to tackle the biggest health issues, to evaluating and developing strategies and technologies on sustainable house building. The impact we have here is far and wide. And we take great pride in that, not only for us, but for our region and our local community. We're an extremely large organisation based here in Leeds. We have 29,000 students and 3,200 staff. And we contribute over £500 million to the local economy every year. Our graduates are the workforce of the future, and we aspire to create exceptional employees, dynamic citizens and enterprise leaders. We have more than 900 academic staff, and I can see a number of them here, covering a wide range of research disciplines. And in tonight's lecture, Clive will present his groundbreaking work exploring the mechanics in neurological diseases such as multiple sclerosis and Alzheimer's. A very, very interesting topic, I'm sure you'll agree. However, in addition to his work here at Leeds Beckett, Clive is the Visiting Professor of Neurology in the Medical School at the University of Buffalo, State University of New York, and he's both a physiologist and a bioengineer who must be a masochist because he holds 2 PhDs. Was one not enough, Clive?
I don't know. Yeah, it was painful.
And he specialises in the use of advanced statistical and numerical modelling techniques to interpret complex physiological and clinical systems. Prior to joining Leeds Beckett, he was Professor of Medical Engineering at the University of Bradford from 2005 to 2015. And before that, he was Senior Lecturer in Aerobiological Engineering at the University of Leeds. Ladies and gentlemen, it's my very great pleasure to now invite Professor Clive Beggs to present his put my teeth back in, too many P's, his Professorial Inaugural Lecture. Are we missing a trick? The role of vascular biodynamics in the pathophysiology of neurological disease. Thank you. Over to you, Clive.
Thank you for coming. I know many of you as colleagues and some as friends and some I don't know. And I'm delighted to have everybody here, and it's great to be able to talk about what I consider a very, very important subject. I've been at Leeds Beckett University in the School of Sport for a year now, or just over a year. And I have to say, it has been one of the most enjoyable years that I've spent in my academic career. And so it's a great credit to all of you who work in the School of Sport. I took early retirement from the University of Bradford, where I was Professor of Medical Engineering, where I did a lot of this work, and I was doing, my background is in engineering. And so I've applied, somewhere along the way, I kind of mutated from a kind of bioengineer into a physiologist. And it's that kind of crossover that I deal with. And my background in engineering was thermofluids. So really this could be, long title, but it could be said, Plumbing Meets Neurology. That could be the title there. It's hugely important because we all possess one of these, right? We all possess a brain, and yet nobody's aware that there's actually biomechanics involved in this and fluid mechanics involved in this here. There's a lot of concepts I've got to get over here and an awful lot of research results to get over to kind of get this picture, so I'm going to have to whiz through it at various rates. But I just want to say a little bit about the School of Sport. My job at the School of Sport, I've lectured some of you here, is on things like computing and mathematical stuff and modelling of systems and advanced stats and things. But this is my physiological work I'm going to talk about here. The School of Sport at Leeds Beckett University is actually much more than just elite sport. It does a lot on health and exercise, obesity and vascular health. So this aging is an area that's particularly of interest to them. And they've got an institute that's researchers in this area. And this is going to kind of stray into that area as well, because aging is one of the areas that I'm particularly interested in my neurological work. So let's press on. Now, I cannot mention all. I want to acknowledge my collaborators around the world. These are clinicians who are in various countries. And Simon Shepherd, who's here from the University of Bradford as well. But I'll mention them as I go along, because time is short, unfortunately. I've got a lot to get through. Right. I want to illustrate how I got into this. This is Professor Paolo Zamboni, who is a vascular surgeon out in Ferrara, the University of Ferrara in Italy. Now, Paolo, I first became aware of him when, in 2009, he published a paper. And this paper, and I'm going to be careful, I'm being filmed here, so I've got to kind of have a very even-handed thing here. Paolo claimed that multiple sclerosis was associated with constriction of the veins from the brain, from the cranium, back to the heart, impeding the blood flow from the brain back to the heart. So principally the jugular veins, but it could also be other veins in the vertebral venous plexus. And he called this chronic cerebral venous, cerebrospinal venous insufficiency, CCSVI. And this became the single most controversial subject in MS research, I think, is fair to say. There have been vitriolic attacks on Paolo and things both ways, right? And I'm trying to play an even hand here, right? So I'm trying to be open about this. And very many controversial claims being made, some of which I think are a little naive, that this causes MS. But this is how I got into it. And the reason I got into it is because I have a family member who's got MS. And I noticed one or two things about them that suggested that there may be some vascular problems. And I was interested. And with a background like mine, I thought I'd better start looking at it. Just to say a bit more, this controversy became even more intense because Paolo Zamboni decided to act on his findings. And he started to balloon patients, perform venous angioplasty. So here we see a jugular vein. We've got a stenosis here. So it's occluded in some way, and the blood is pooling up here. You can see that. And then you put a balloon in, open it up. Interventional radiologists and vascular surgeons do this kind of stuff all the time. Open it up, and then the blood flow flowing down the jugular vein is kind of normalized. Now, this became highly controversial. And since 2009, many thousands, in fact I would say many tens of thousands, I've met many clinicians who perform this operation, not in the UK but abroad, and I've met many patients who've experienced this operation, and there have been mixed results. I've met patients who say their lives have been transformed and changed. I've met others who've no effect on them, and I've met, well, sadly there's not enough published reports. The clinical work on it is not. There's just not enough of it. But from the evidence and talking to people and also from various papers, there seems to be some respond, but it's a short-lived response as well. Right? Just to give you an idea, this is a hugely controversial subject. Since 2009, there have been many, many papers published on this subject, both for and against. I couldn't put them all in, so I just put two. This is Comby's paper here. Most of them using ultrasound, venous ultrasound, to actually see if they could find this blockages, the CCSVI. And this one here, they had MS patients, people with other neurological diseases and healthy controls. They couldn't find any difference. CCSVI is not associated with MS. You couldn't get it any blunter than that. And at exactly the same time, another study, Zanussi, reasonable size study, 82% of MS patients had stenosis or CCSVI and only 14% of healthy volunteers. So contradictory findings all over the place. Now, I'm now doing work with the guys at Buffalo, the last few papers, where we're actually looking at the physiology of the neck to try and understand the collateral veins and the jugular veins in the neck, and to understand at the various levels from C2 down to C7 how they change. and how they change with age. And what we're finding, they change with age, sex. There's a lot of variation, and they change as the body changes, right? And it's different in males and females. So one of the reasons we might have so much contradictions is because these guys are some doing it at C5, 6, and others doing it at C2, as I will show you later on. And one of the things I've been looking at is to see how we can get around more evidence to see what's going on. And of course, all the time, we've got these patients who are claiming that they're improved by the procedure. And this has led others to say, well, this is just placebo. So we have a physiological mystery, or a myth, depending on how you look at it. And this is really where I stepped into it because of my background. I was interested in this, and I wanted to really understand, how, if you've got occluded veins, how on earth can that affect demyelination in the brain? What's going on at a neuronal level in the brain parenchyma? Is there a physiological connection? I hope to show you later on that there is some physiological connection. But the problem is it just a myth? Is it actually going on? And if it is going on, what's going on? And are these things just placebo? Are there any benefits supposedly just placebo? So I've tried to be an honest broker to try and bring clarity to what has been a heavily polarized and in many times a vitriolic debate. And I want to bring, I've tried to be in the middle, trying to understand what's going on. Now, I have a problem here, and a unique problem. This lecture has got individuals who are clinicians. We'll have neurologists here, and I will have members of the public here, and I will have people who have no understanding of what's going on inside the cranium, and others who do. So I feel incumbent that we have to give you a lecture in about 2 minutes, 3 minutes on cerebrospinal fluid and veins in the cranium, right? So here goes. Pay attention, right? Right, now, I'm in a school of... Oh, no, we're going to do an experiment, first of all. So I all want you to do an experiment. You can do it on a friend next to you, but they may not like you for this, especially a stranger, or on yourself. So I'd like you to feel your cranium. Go on, just feel it, prod it, give it a check it. Feels pretty hard, doesn't it? Yeah? Right, now I want to prod. You can prod whichever part of your body, right? Or your neighbours. Prod other bits. Discreetly. Are they hard? They're all soft. You're soft. This is hard. This presents the body with a great problem, right? When we look at the blood flows, it presents a problem. But it presents the brain with a problem. The reason this is hard is to protect your brain, basically, right? Now I'm in a school of sport, and little did I know when I came here that one of the hottest areas in sport, in rugby, was concussion and brain injuries. And I'm sure I'm going to be roped into looking at concussion. I haven't done any work on concussion up to now. Because if you've ever watched a rugby union match, and Mike Gray tells me this, that when two players, they're big guys, yeah? And they smash into each other, I've been told that it's the same impact as two cars hitting each other head on at 30 miles an hour. Am I right on that? Yeah? Now, think about it. We have this brain. Now, I'm going to give you a word if you don't know about this. Your brain, right, that's made up of neurons, cells, nerve cells, oligodendrocytes, astrocytes, blood vessels, and water. It's incompressible. It's an incompressible jelly. It's a gel, right? A blob. And it's sitting there. And you've got a brick wall, which is your cranium. So you've got two rugby players crashing into each other. Your brain is going to go into that, and it's going to have bleed, and it's not going to be good. But the body's got a mechanism to protect you against that, and it actually has a sea, it floats it in a sea of water, right? Technical term for cerebrospinal fluid, water with stuff in it, right? That's what it is. Yeah? Blood plasma, water with stuff in it. You can tell I'm an engineer. Right? So this water, this floats in here, and that protects it from impact. But there's ventricles, there's space in the middle of the brain, in something called the choroid plexus, is where it's produced. And actually it comes from the blood plasma. It's water coming out of there from the capillaries that are near the arterial side and percolates round, removing metabolites to a certain extent. And it percolates round, down the spine, which goes down here, round, this is called the subarachnoid space, round here, and then it passes in through something called the arachnovilli, and it passes back into the blood and joins it again here in the sagittal sinus into the venous blood. Right? So you get this percolation going round. And this is at the heart of all the biomechanics of the cranium. Right? And if we look at the venous side of things here, there's one other thing I should say. Of course, there's one other crucial thing, which I suspect is involved in concussion as well, but I don't know for certain. Crucial thing is this is using up lots and lots of oxygen. It needs fuel. So there's got to be blood supplies. So we have arterial arteries, PL arteries that come up and run in that subarachnoid space, surrounded by fluid, the cerebrospinal fluid, and then go in there. And of course, if you've got blood going in, you better have some blood coming out, the venous blood coming out. And that comes out from the cortex and other routes as well. I'm simplifying it a bit. The cortex is the outer bit of this brain parenchyma, right? That's what we call it. And it comes out, and they run down here as well. And we call them cortical bridging veins, and into the sagittal sinus here, right? That's really important to what I'm going to talk about. Anyway, all the venous blood comes down here and down the straight sinus, along the transverse sinuses, and down the internal jugular veins. Now that's a lie, because the slide is a simplification. There is also vertebral veins and the vertebral venous plexus, which tend to predominate when people are vertical. The internal jugular veins tend to predominate when you're horizontal more. Right? I think that's the lesson over for physiology of the cranium. Now we have an interesting thing. I want to go back to your body. We do imaginative science here. So now we look at your heart. Your heart's got 4 kind of vessels in it, but it's the left ventricle is the one that does really all the big work, right? So imagine your heart is just a big muscle, right? And it's got this cylinder, and at the start of the heartbeat it goes like this, and a big slug of blood is sent out into the aorta. In systole, the blood pressure goes up, and then so it goes right up above the mean. So if you imagine that's the flow there, it goes right up to the peak, and then it drops in diastole down below the mean. And that's not a problem, because you've already proven to yourself that your body is soft. So all your vessels have compliance, they give. Yeah? What happens when you've got 40% more blood going into that's rigid in systole? That will crush your brain parenchyma, or get shear stresses on the endothelia that will cause all sorts of problems. So the body's got a beautiful bit of, for those of you who are engineers in the audience, this is mechanical engineering par excellence. We have a beautiful Ventricular mechanism that ensures that in healthy young adults, we have smooth blood flow through the vessels in the brain parenchyma. And basically what happens is we have a Ventricular mechanism in those PL arteries that run in the cerebrospinal fluid. They expand and store the blood in systole. So they store all this extra blood, and then they push cerebrospinal fluid out through the foramen magnum into the spine. So it displaces it. And then that comes back in diastole, and it pushes it back and ensures smooth flow through the parenchyma. But it also transfers the pulse over to the venous side here. So you get a reduced pulse, but it tells you something about what's going on. And we also get a pulse up the aqueduct to sylvius, which inflates these ventricles. So we get this whole bit of mechanical engineering going on, which is poorly understood, to be honest. And you can tell I'm an engineer. This is my square brain. Easy to draw on PowerPoint, right? But essentially, what you've got here, it says it all, really. There's the internal jugular veins that are way out here. This is the arterial blood coming out. It expands, pushing out cerebrospinal fluid and systole, making sure this is smooth flow through here. And then it comes back over here. And the interesting thing in these cortical bridging veins, they act as Starling resistors. So it actually puts a pulse back in there, and also through the arachnovilli. And then we also have the cerebrospinal fluid that percolates through this whole thing, through the aqueduct to sylvius there, round, and percolates through there as well. And it all comes in. So that's the physiology, right? Now we get on to the signal processing and the work. Now this is really the last paper that I've done, my most recent paper. We've got this kind of accepted subject to the revisions. We've just done the revisions and we're just sending it back in with Simon Shepherd. And Simon and me did the signal processing on this. It's with the team of Marcello Lagana in Milan. And what we did here is we took 12 healthy young adults. That's what we did. And we took MRI through the C2. And this is one of them. And I just want to show you the signal. So this is in the neck, the upper neck, right? And so what we've got, here's in systole, the arterial blood going in goes to a peak. And what it does is it pushes cerebrospinal fluid out down into the spine at that point. And then in diastole, it drops down to a minimum here. But if you look at the venous coming out at the same level, what you see is exactly the same, but a dampened pulse and a slight delay. But notice here, you've got more blood going into the cranium at that point than coming out. So you must have storage of blood in the cranium going on. And then in diastole, you've got more coming out of the cranium than going in. So venous blood must have been stored. And then it's coming out. And understanding what's going on in the cranium, this is in the neck, remember, nobody has been able to do until now. We've done it. And so of all my papers that I've done quite a lot in many subjects, this is the one I'm probably most proud of, right? So you can see it here for the first time. I won't do that. So we did 12 individuals there at C2 through there. And what we did was we looked at all the blood going in the arteries, all the blood coming out in the veins, and the cerebrospinal fluid. And we also did the aqueduct, which is there, right? Cerebrospinal fluid there. And this is the data aggregated. And you can see it's very similar in pattern to the other. A bit smoother because there's more people, right? And that, we signal process that. Because you've got incompressible fluids, a rigid container, so all the information must tell you what's going on there. It's just that nobody can understand it. And we did a nice bit of signal processing, and that's what we translated it into. Right. And that makes sense to an engineer who knows about fluids, because it's what happens. So this is diastole here. This is the first in the world, this is right. And these are explaining normal physiology here, by the way. There's no pathology here. So this is the systole. So let's talk about what happens in systole. As the arterial blood comes into the cranium, so it first of all pushes out cerebrospinal fluid out into the neck, right? So that's the volume in the cranium disaccrete. And then after that, as it increases, it pushes out the venous blood out of the cranium. And then finally, it deflates the ventricles. It starts to deflate the ventricles, the order, through the neck, that, and then the ventricles. Going the other way, as that starts to decrease, so the cerebrospinal fluid comes back in, followed by the venous. But notice there's a lag between these things here. There's compliance in the system somewhere. And then followed by the ventricles. There's a lot going on there. And you wouldn't believe it, but that translates to that. And it took us quite a bit of time to do that. That's why no one else had done it, but we were very pleased with it. But if you were to scale that and the veins and the flow in the aqueduct, you find that. They're almost identical signals. But the veins lead the aqueduct. The veins lead the aqueduct, which implies that they are influencing the flow up the aqueduct of Sylvius. That's the important thing, right? And this really is the source of all compliance in the brain, other than the spinal compliance, right? Now, it's not surprising because these cortical bridging veins actually run down the subarachnoid space. They're surrounded by cerebrospinal fluid. And these are thin-walled vessels, very thin-walled vessels. They're floppy. They collapse and they expand. So if you know where I'm going, if you can occlude the jugular veins, the blood will build up in these areas here and it will have an impact on the cerebrospinal fluid. So there's a relationship. And in fact, all the functional compliance in the brain comes from these vessels. Because what happens is, there's a starting resistor, they collapse under the pressure of the intracranial, well, the cerebrospinal fluid, and then the blood flow builds up and they puff out and then they push out, so you get a pulse again, right? So it's the free egress of blood that's really, really important in this whole thing. Long ago, people realized that there was a delay between the venous peak going out and the peak coming in, but you've got incompressible fluids in a rigid container. From an engineering point of view, that's difficult to explain. And we see this arteriovenous delay, which is a surrogate of the intracranial compliance. And this is not my work, this is Grant Bateman's work out in Australia. And if you've got atrophy, you find that increases, so the compliance is increased. But if you've got like normal pressure hydrocephalus, which is another neurological disease, it's greatly reduced. So if you get a great reduction in that, then that is an indicator that something's changing in the biomechanics of the cranium. Right? The compliance is changing. And the thing that gives the compliance, this is a really crucial thing, is that these veins, these cortical bridging veins, being able to discharge. So if you squeeze them, the flow goes out. But if you've got the resistance starting to build up, they are going to back up and change the whole compliance of the intracranial cavity and whatever happens. We'll talk about that later on. So it's that free egress of venous blood. You can see where I'm going with this, can't you? Right. I've never worked with Grant Bateman. I've met him at conferences and I correspond with him. But he sent me this paper, which he's just published, on MS. He's done lots of, he looks at the blood rather than cerebrospinal fluid. He looked at the pulsatility in it. And he did it with the MS patients. And he found that that arteriovenous delay, the intracranial compliance basically, was a 35% reduction in the MS patients and a 58% reduction, very strongly significant, in the normal pressure hydrocephalus patients. What I'm going to say is that these, he didn't measure the venous side, but these are consistent with constricted venous outflow. So, quite an exciting paper. So moving on to my work now, right, with MS. There's an awful lot of contradiction between the studies with ultrasound, and Paolo Zamboni developed an alternative method to assess an engineer's method for assessing the blood flow from the brain back to the heart, cervical plethysmography. And he wanted to understand the signals, so he called on me and Simon to try and interpret these signals. And I did that, and then I discovered a way of actually quantifying the hydraulic resistance in both groups. So we have two papers that were published a couple of years ago. And really it's classic engineering. So I want you to think, small rubber collar, plastic tube, rubber tube, yeah? Expandable rubber tube. You put it around passive, it's just passive, around the neck, filled with kind of liquid metal like mercury, yeah? Not mercury, but like mercury. And then you pass a small electric current in. You flip the patient's back on the back, the blood collects in the neck, like the venous blood. They expand. The vessel expands, the diameter gets less, the resistance increases and it creates a signal. So we flip the patients back, then we flip them back, and as the blood drains away, we look at see what happens. And here it is. There's the signals. So when we flip the controlled patients back, when you flip them forward, the blood collects, and you get this instant drop. It drains freely back to the heart, no problem. Then we do the MS patients. And what happens is it drains back, and then it kind of backs up, and it goes back slowly, much slower, implying that something's not allowing the free flow of blood. And the best example I can give is the toilet. I'm sorry here now, I'm getting very basic here, right? Now you've all been there, right? You've all used the toilet and you've all been it, but you know sometimes it gets blocked. I won't go into what it gets blocked with because we're being filmed and that, but you can imagine if you haven't had this problem, you're very lucky, right? And sometimes you can't even see what's blocking it. It's blocked down there. And what's happening when you flush it, it backs up, doesn't it? Right? What happens is actually the water goes down, first of all, until the amount of water flow overcomes, basically it's too much for the resistance, then it backs up, which is exactly what we're seeing here, right? And then drains away slowly. Sorry to bring the toilet up there, but it's there. And what I did was then for the second paper, built a hydrodynamic model, mathematically was able to interpret this. And what we found was that in the MS patients, and we had 44 of them and 40 controls, we got a 63% increase in the hydraulic resistance, which was very strongly indicative of something going on here. We're not looking at any one vein, we're looking at the whole system. Right? So the next thing is, to notice is if you have an occlusion, here's a vein here, you have an occlusion of some nature, the flow will stop, reduce, you get hypoperfusion, but you get hypertension, increased pressure above. It's just the physics of it. I don't have the time to talk about it, but it was what happens. And that increase in pressure goes all the way up. So we would expect to see, and I calculated it from the results, and I reckon it's about 2 to 3 millimeters of mercury, what I would call subclinical increase in pressure in venous hypertension, right? Below 5 millimeters of mercury, definitely, right? So let's say 2 or 3. And Paolo Zamboni actually measured it at 2 in his patients. What that will do, what you've got to realise is that there has to be a pressure gradient or a pressure drop across these arachnovilli for the cerebrospinal fluid to actually move into the blood. If there's no pressure drop, if this increases, that will reduce. So that's another indicator we can look for, right? Also, the compliance of this here will all change as well. This vessel will change. And in fact, this rate at which it's absorbed through the arachnovilli has actually, back in the 60s, it's been shown to be a linear relationship influenced by pressure. So we can make some fairly good assumptions. So we would expect, if this was going on in the MS patients, we'd expect the compliance of this whole area to change and the rate of the transfer to change. So we now go back to 2012, and this is with the guys in Buffalo, with Robert Zavadnov, and Chris McNano led this project. And sure enough, we saw a reduction. We had 67 MS patients, 35 healthy controls, and what we saw, sure enough, about a 50% reduction and strongly significant reduction in cerebrospinal fluid absorption, right? So which is consistent with venous hypertension. They didn't look at the veins, by the way, on this, or we didn't look at the veins. And then the pulsatility in the aqueductus sylvia, it became much, much more pulsatile. It increased by 45%. And this is something other independent studies have shown as well in MS patients. So we're seeing biomechanical changes going on here, which are consistent with venous outflow problems. Last year I published this in PLOS One. And what we did there was we looked at the various levels, C2, C4, C5, C7, yeah? And we looked at the relationship between the cross-sectional area of the veins in the MS patients and the pulse in the aqueductus sylvius. And you can see that we see no difference up at the C2 to C4, but it's in the lower neck. We start to see the veins getting lower, and we saw the increased pulsatility just as we saw in the other studies. Right? Very strong positive results in that. And then just to add the icing to the cake, we then did an interventional study, at the same time we did it, with teams with Paolo Zamboni and Robert Zavadnov. And this was on patients with MS, diagnosed with CCSVI. We did the MRI on the aqueductus sylvius before and after, and we did the intervention. And what we saw was that pulse, that increased pulsatility, normalized, or tended toward normal. So we've got quite a lot of evidence here, all pointing to sort of venous anomalies. I like to use the term venous anomalies going on here, associated with MS. But of course, this may not just be to do with MS, it may be to do with healthy individuals. So again, with the team in Buffalo, we did this study, and I led this one, where we had healthy individuals. We found it quite difficult to get the CCSVI positive healthy individuals, but we found them who were diagnosed with ultrasound, and then we looked to see if we'd see anything like the same. And we saw exactly the same. We saw reduction in the absorption of the of the cerebrospinal fluid, and we saw an increase in the pulsatility. And look at the diagram. Look at that diagram there compared to that diagram with the MS patients. Exactly the same. So this told us that this was a biomechanical effect which was completely independent of any neuronal decay or immunological disease, which was interesting because that may mean it might be another feature of other things. And actually, I searched the literature and I found this in someone's PhD in Sweden, I think they were. And I'd seen reports that increased pulsatility in the aqueductus sylvius in normal pressure hydrocephalus. Normal pressure hydrocephalus, by the way, is another neurological disease that shares some clinical symptoms similar to multiple sclerosis, but is diagnosed differently, right? But again, we see increased pulsatility there. and this is really the icing on the cake for me. This was a great paper by Hatt et al. In the American Journal of Neuroradiology, and came out last year or the year before. And basically what they did was took healthy individuals, compressed the jugular veins, and looked to see what happened to the aqueduct, the pulse in the aqueductus sylvius, and the stiffness of the brain parenchyma. And what they found was the brain parenchyma stiffened, it changed its qualities, and the pulse became more pulsatile as we expect. So this is all pointed to veins being important in the control of the hydrodynamics of the brain, basically. And this is not surprising, because if you go back to the 60s, Katana's work, what you find there is that he compressed veins again, didn't do the MRI of the aqueductus sylvius, but found the blood increased in the cortex, which is what I would expect, by about 17% or so, which would account for stiffness, stiffening up the brain, and reducing the intracranial compliance of the whole cranial cavity. So we have lots of evidence. So I've got a lot of time to go through, so I won't submit a lot to get through, so I won't summate that, but I've gone through it quite carefully. Basically, lots of evidence, which is all pointing to that venous anomalies may be associated. I'm very cautious when I say these things. I'm too used to writing papers with MS, right? We're providing evidence of what, from an engineering point of view, what's going on. But then further and above that, we are saying that this is a general biomechanical effect that affects anybody, which is interesting, and that it profoundly changes the intracranial compliance of the whole space, and maybe irrespective of any underlying disease, right? Conclusion, right? And in fact, if Mark Wilson, who is a neurosurgeon down at Imperial, does a lot on trauma. And he just published a paper last year, which I thought was a great paper, but it basically was not looking at this problem, but he came with a complete conclusion that the venous pathology is central to many conditions involving raised intracranial pressure. He's talking there mostly in trauma. I'm talking subclinical stuff. Right? So I come to this point of intracranial compliance. Now, Grant Bateman has probably done most of the work on this stuff, and he did quite a few neurological diseases, and he, as I said, he found a 35% reduction in the arteriovenous delay, intracranial compliance in the MS patients, 58 in normal pressure hydrocephalus, and 36 in Alzheimer's. This is a disease with atrophy of the brain. What's going on there? And what's more, we know that pulsatility is increased in these two diseases, and we know that these share many similar clinical features. So this makes me think that maybe there are other things going on neurologically that need to be looked at here. I've given all the references, by the way. You can go and check these out. You know? I did with Chi-Pi Chung in Taiwan and Robert Zavadinov, we did a couple of papers on Alzheimer's and elderly patients. She's done a lot of work looking at white matter damage and venous reflux, which is similar to CCSVI, and found increases in older elderly people as they're aging, increased damage, white matter damage. We found an amazing finding here was that this venous anomaly, the brains of you'd expect people with Alzheimer's to have a lot of atrophy, right, on MRI. Their brain parenchyma volume will reduce, especially the cortical volume. And what we found was it was much bigger than we expect it to be. And we puzzled about this. But what I think is happening now is actually the venous blood is engorging the veins, increasing the brain parenchyma size. So it's actually a biomechanical effect in that sense there. So I'm now going to come on to the clinical side of things, right? Or what might be going on here. So I believe we've got clear evidence that veins are very, very important to the biomechanics of the cranium, and that these things may be associated with certain neurological conditions. But so what? You know, it may make no difference at all, may be completely unrelated to any neuronal decay. What are the clinical implications of this? Well, you appreciate I've been spending all my time even establishing what we've got so far. We're now moving on to try and understand what this means, right? From a pathophysiology point of view. Now, there's lots I could say here, but I've got to cut it down and can keep it under time. So I want to put two major candidates. One I know is certainly happening. The other is possibly happening. This Ventricular mechanism, right? As you age, your vessels, your arteries, they change, they remodel. The collagen changes in them. They become less compliant. If you've got hypertension, high blood pressure, your vessels become less compliant. And what happens is, in healthy young adults, this is smooth and pulsatile, the flow through here. But as you age, this becomes more pulsatile, because this Ventricular mechanism doesn't work as well. And we think that that's associated with things like vascular dementia changes. Now, we all know that if we change the pulsatility in the rest of the body, if those of us who work in cardiovascular work, the morphology of you get plaque buildup, you get all sorts of things going on. But nobody's really turned it much to this. And so we're now starting to look at the brain-heart axis, and especially with aging. So this is a big, irrespective of any venous problem, this is a big issue in aging. Right? But if you reduce the compliance, you'll also impair this here. And you would expect to see more pulsatility going into that there. So this may change things here, and I'll talk about that in a minute. The other thing that you may also have, if you've got increased pulsatility in the aqueductus sylvius, you may start to get ventricular reflux. One of the things we notice, by the way, in a number of these conditions is that the ventricles are bigger, right? So in MS, in Alzheimer's as well, and normal pressure hydrocephalus. And the question is that due to atrophy of the brain parenchyma, which is generally the case in MS, or is it, as in normal pressure hydrocephalus, maybe due to a buildup of cerebrospinal fluid, and if you then shunt it away, it comes back to a certain level, right? Back to its normal size. But one of the things that can happen is you can have breakthrough of cerebrospinal fluid across the ependymal wall. And this is the region, the periventricular region, which is where we find the lesions in MS, or many of the lesions, and other problems in other neurological diseases, certain neurological diseases. So these are the two areas that I think are really important to look at. And I now got to give you a bit of a lesson on pulsatility, endothelia, and vascular disease. So pay attention, 1 minute lesson on vascular disease. When you've got pulsatility, right, first rule, I'm simplifying here in every way, is the blood vessels get very used, whether it's pulsatile or smooth flow, they get used to what they're supposed to be used to, right? They have so if it's smooth flow through the brain, they're used to smooth flow through the brain. If it's a pulse in your other vessels, regular pulse, they're happy with that, right? But when you start to get turbulence, when you start to get increased pulsatility, and you get that when you get hypertension, you change the compliance of the vessels. From a fluid mechanics point of view, you get whew, whew. And these endothelial cells that line these vessels, these are not innocent cells. They're attached to the basal lamina by integrins. And those integrins don't just anchor them there, they act as transducers. They send signals and saying, yeah, we're okay, we're okay. Yeah? You know, nitric oxide is put in there, keeping the smooth muscle nice and smooth. Once things start to change and you get pulsatility, it's well known. We start to get things like increased pulsatility, we get atherosclerotic plaques forming in other parts of the body. We might get morphological changes going on. So why not in the brain? Well, in fact, there is one disease where that has actually been looked at to do with aging. Small vessel disease, commonly called leukoariosis, which is actually a radiological finding, where we start to see white matter damage in the periventricular region round the ventricles. And here we can see it. And it tends to happen in older individuals with hypertension and with cardiovascular disease, and it's associated with stroke. And Bateman, again, did work on this and found the pulsatility was increased in the vessels. So there was probably increased pulsatility going through there. But a lot of work has been done on the histopathology of this, and you can start to see, look at these arterioles here, look how tortuous, they become completely contorted and increase and change. And they're all going down towards the periventricular region. And then we get periventricular collagenesis. Moody and Brown discovered this. And the vessels change, the morphology of the cell walls change, and they decrease. The long and the short of it from an engineering point of view, a fluid mechanics point of view, is you increase the length and the thinness of it, you increase the hydraulic resistance. So the blood can't get down there. And what you find when you look at this damage here, it's ischemic. There's a lack of oxygen. Hypoxic stress, ischemia. And the periventricular region is right at the distal end. And that's where we start to get the white matter damage. And this can lead to things like vascular dementias associated with this, right? Well, very little has been done on this really outside of leukoariosis, and we actually started to do some work on this. And what we did in the subsequent paper is we looked at, in healthy individuals, whether increased pulsatility was associated with early stage white matter damage, what we call dirty appearing white matter. And we found, yes, it was, and we published this last year. These are the guys in Buffalo. And we started to see similar results to, Joly works with Bateman, right, and out in Australia. And they, again, also found early stage white matter damage in increased pulsatility in the aqueductus sylvius and in the blood flow. Chung didn't do pulsatility but did do the venous side, and they found increased white matter changes in elderly people. And McNunno found that the increased pulsatility was associated with extra load, lesion load, in the MS patients. But of course, that could be completely just both caused by another cause, The biomechanics has changed, they've got MS, they're going to change, It doesn't mean there's any cause with it, causal thing. These are just associations, but these are in healthy individuals, But what we do know is that down to the deep white matter, numerous studies have shown this in MS patients, we have reduced perfusion, even to normally appearing white matter. And this suggests that vascular changes may be going on, and it's been hypothesized that you might get hypoxic stress, ischemic stress, that may be causing the occludens to open and the blood-brain barrier to open, leading to leukocytes to go into the parenchyma and attack the neurons and the demyelination, right? Because the big thing about MS is breakdown of the blood-brain barrier. That's the key thing for neuronal damage. And I don't think anybody's really done a lot of work on this here. There's bits of studies on it, but how changes in the biomechanics of the might affect it. And we're going to be running out of time, so I've got to do this quickly. But these are you can see the similarity with this, by the way, with the leukoariosis. But this is MS, the periventricular regions of the veins there. And these are the periventricular veins. It's these kind of fine veins here. But it tends to happen both sides, which is interesting. What we call so-called Dawson's fingers. We have this, which suggests that it may be to do with systemic changes in the blood flow, in the whole thing, affecting the whole of the brain. So it's even to both sides. These are very much at the distal region, but of course they're very, very close to the ventricles as well. So we may get other things going on here. And this is where we have to go back to Adams in 1987. But I think this is well worth looking at. Certainly in normal pressure hydrocephalus, there's evidence that there is breakthrough of ventricular reflux. And that causes, if you think about it, you've got an electrolyte balance. You've got a whole lot of neurons that kind of have action potentials, and they rely on sodium channels opening, and everything has to be balanced. And suddenly you get a load of cerebrospinal fluid going in. That starts to change everything. But also, it changes the oncotic pressure, and you start to get edema forming, right? And what will happen is that not only messing up the electrolytic balance, but it can also crush the vessels or constrict them. So again, you could be ischemic damage further down. And I think that this is an area that really needs to be looked at, either eliminated, because if we're seeing changes, is this going on? And we certainly know that the ventricles have changed in size. I don't know. I'm trying to take it on from the biomechanics into what the connection really there. So I've got two slides that I've done because I thought someone might want to ask me about the venous angioplasty. I'm very, very I've got to say a bit ambiguous, right? Mixed feelings, that's that. But I want to give an honest, open-handed answer on this one. So I've prepared 2 slides, which I'll encourage people to ask me about in the questions, because we're going to run out of time, right? Otherwise. And so these are my conclusions. My conclusions are that the veins are crucially important in controlling the biomechanics. Free egress of blood is important in controlling the whole of the hydrodynamics biomechanics of the intracranial space. Stiffness of the parenchyma is heavily influenced by that. It's manifest in various ways, and it will change the dynamics. But we see that these dynamics are also there in MS patients, these changes. So it leads me to suggest that there is venous anomalies associated with MS, or with some aspects of MS. And very possibly with other neurological diseases. So this means it's extremely important from the point of view of there's a lot of neurological disease, and we all own one of these. And this may be something that's going under the radar, because as an engineer, stuff gets around the body either by crawling on integrins very slowly, or takes a lift in fluids, either through the blood or by diffusion. And the brain has no lymphatic system, so stuff has to get around the brain. You've got, I think, is it 20% of the metabolism of the body? You've got a long way to get. So how do the metabolites get out? And if things are getting messed around, what's going on? So you can't get away from the fact that there's got to be spatial things. There's stuff has to get from one place to another, right? That's what I'm getting over here. So I would suggest that this may well be involved in the pathophysiology, but all I will say is contributes to it. I'm not saying MS is caused by this, right? I'm very careful on that. What I would advocate is that we look very carefully at the whole idea of pulsatility in the brain and endothelia. This, irrespective of any veins, this is for aging and vascular dementia and vascular health, and for all of us at the School of Sport from exercise, And also we know that obesity changes it as well, BMI. We've been looking at that, and that changes the dynamics of things. It certainly changes the pressures in the intracranial cavity that affect the drainage, right? And that. And then the other area I think people should be looking at, I don't know whether I will end up doing this or not, but is this whole area of ventricular reflux into that region of the periventricular veins. And that is really all I've got to say.